Good morning. My name is Lori Ringel. I'm an emergency room social worker at Good Samaritan Hospital in Mount Vernon, Illinois. I have been with SSM for 7 years and have worked in the social work field for 14. I'm very honored to be here and to be a part of SSM. I was drawn to social work from the time I was in grade school. My favorite teacher told me that I would be the first to notice a fly on the window. Ouch. But then she told me she also noticed that I knew when others had a problem or they were upset. This made an impression on me, and as I continued on to high school and college, I knew I wanted to pursue a career in social work. When I was 10, a girl my age was kidnapped, raped, and murdered in a small nearby community. This kind of tragedy was unheard of in our area, and it changed the way our community viewed safety and prevention services. My first job in social work was at an advocacy center that was named for this young girl. The center was developed to focus efforts to protect children and victims' rights. It has made a major impact on legislation doing just that. This kind of impact and opportunity for positive change is needed in many areas of healthcare. I see this every day during encounters with patients in the ER. The lack of access to resources, particularly in mental health, is most challenging. Many patients are sometimes held in our ER for days, waiting to be transferred to psychiatric facilities. They also wait for months for an opportunity to get an appointment with a psychiatrist or a therapist. Because of these barriers, patients end up in the ER frequently asking for help. In an effort to help them get the care they need and to reduce unnecessary ER visits, we started focusing on the patients with the most visits. We started with individual assessments, which led to starting a support group that we held every Wednesday in the hospital. One of the patients I worked with had around 60 ER visits in 3 months. She had a history of bipolar and depression and had no provider at the time. During my assessments with her, I learned that she had been homeless since the time she was 16 and was currently staying with an ex-boyfriend. I worked with her a lot over the next couple months and really focused on her emotional needs. We were able to get her established with a primary care provider and moved her to a homeless shelter. She became involved in church and she found many things she liked to do in the community. We developed a care plan with her, and she identified times she needed to call her provider or myself as opposed to going to the ER. She also participated in the support group where she acted as a leader. She completely stopped coming to the ER, and in the next year she only had 1 visit. She has since gotten married and is doing well. This kind of success story helps me know that I am making a difference and inspires me to keep going, especially for those patients experiencing the hardest of times. Much like in the case of a patient we will call Jack. Jack was in his early 30s when he presented to the ER last November. A concerned citizen who saw him stumbling down the road picked him up and brought him to the hospital. We found out that Jack had eloped from another medical facility. They told us that he had been in a nursing home where he had become violent with staff. We also learned that he had suffered a traumatic brain injury after attempting suicide by hanging just 6 weeks prior. Before going to the nursing home, Jack had been in intensive care and then a rehabilitation unit. Neither facility would accept responsibility for Jack, so he was admitted to our ER. Jack could not provide us with much history, medical or personal. He was ataxic. He had slowed speech with no expression, and his memory was severely impaired. He did not understand why he was there, and he kept asking for his wife. We could not reach her or any other family. We started pursuing psychiatric placement, but these attempts were unsuccessful because psychiatrists felt that the behavior was not treatable in an acute setting and that they were caused by his brain injury. We began looking for placement options for him at traumatic brain injury specific facilities and nursing homes. I had no idea what roadblocks were to come. There were facilities that could not accept Jack due to his age at the time of the injury, others because of his payer source. Other deterring factors were that Jack had a criminal history and he had been in prison a couple of times. Also, that he had untreated mental illness and substance abuse problems. I saw Jack almost every day, and I would explain to him what we were trying to do to help him. He would ask about his daughter every day. I could not imagine how he felt when we explained that she was 4 years older than what his memories were. Many times Jack had questions about what happened and why he couldn't remember anything. He usually asked if he and his wife were still together. These questions were hard to answer, but we wanted him to know the truth. I did eventually make contact with his wife. She shared family history and that Jack grew up in a children's home after his parents lost custody of him at the age of 12. He did have some contact with his mother and brother. Unfortunately, his wife was reluctant to take full decision-making responsibility and planned to divorce him. After about a month, we finally found an accepting facility. This was great news, and everybody involved in his care was so excited that he was going to a place that would help him. Things went well there for about a week until Jack assaulted another resident. He returned to our ER, and the process of placement started all over again. Jack stayed at our hospital for about another 2 months while we tried to find him placement. Over 50 facilities or programs declined him. I cannot say enough about the care that Jack received while he was with us. Staff provided exceptional care in a difficult and unfamiliar situation. They spent time with him, answered his questions, and showed him patience. He was comfortable with us, and he never had one violent incident. Staff also took up a collection for him so he could get a candy bar, a snack, a soda. Mountain Dew was his favorite. And he did have a couple pizza parties. He also had Christmas gifts, thanks to some of our anonymous givers. Over time, Jack showed improvements. He was responding well to his medications, and he was in a good routine. He was walking better and talking better, and he was regaining some memories that he liked to share. His wife and daughter visited a few times, which really lifted his spirits. He even started showing his personality, like when I told him it was almost Super Bowl. He perked up, and he said, "Can we get a beer?" I changed my focus of discharge plan when it became apparent that no facility was going to take Jack. I worked closely with his mother, who now lived in Indiana, to be able to care for him. He was set up with a doctor there and referred to in-home brain injury services. I know his mother was nervous about caring for him. She had seen him for the first time in 7 years when he was in critical care. The smile on Jack's face when he learned where he was going was priceless. His wife and daughter planned to stay in touch with him, and they came to tell him goodbye the day he left. About a month after discharge, I spoke to his mother, and she said Jack was doing well. Caring for Jack was a great collaborative effort, and I know many of us will always wonder how he is. We remain grateful that this experience reinforced our conviction in what we do, reminding us that whether we have 5 or 50 rejections, we are champions for our patients, pushing forward to provide compassion and ultimately reveal the healing presence of God. Thank you.